We have next Dr. Jodhbir Mehta is going to talk to us about endothelial cell therapy for decompensated corneas.
Thank you, Ash. So I'd like to thank the organisers for the invitation to talk in this session. So I'm going to give you an update really on where we are endothelial cell therapy, which is a very hot and fascinating topic for decompensated corneas. So as most of you be aware, there's been a massive change in the face of corneal transplantation performed around the world, with endothelial keratoplasty becoming the leading procedure. And you can see data from EBAA above in 2012 and in Singapore back from 2008, where it really overtook us, penetrating keratoplasty as the leading indication for endothelial replacement. And the reason why we basically all shifted to these lamellar surgical techniques is because, of course, we get better outcomes in the long term. And you can see this from this Kaplan-Meier survival curve on the right-hand side when you compare EK and anterior lamellar techniques compared to penetrating keratoplasty techniques over a 10-year time period. Now, the reason why there's been a lot of buzz and there's a lot of interest in basically endothelial-based surgical procedures with respect to cell therapy is because the cornea is the perfect model for basically cell-based therapy. Of course, we can change the epithelium and grow this out in the lab or grow this on the surface of the eye. Keratocite cell therapy is still at preclinical stage. And of course, endothelial cell therapy now is coming into basically clinical trial situations, and I'll focus a lot of that in my talk. The other thing is that most of our patients have endothelial disease that we actually do routine corneal transplantation for. So the impact, of course, is going to be very high. When we think about endothelial replacements, there are really two groups that really push the limits with respect to cell culture. Professor Kaneshida's group in Kyoto have really done an amazing job to basically get this all the way basically to clinical trials and approval for use now in Japan itself, and have really pioneered a technique of basically doing cell culture of endothelial cells, so expanding them in vitro. And they use a technique essentially where you use one media to basically proliferate the cells out so you have enough cells. Our technique in Singapore is slightly different, where basically we use a technique of basically where we call it a proliferative media, then a maintenance media. So we do this media switching technique itself. And the idea of doing this is to maintain the morphology of the cells before we basically put them back into the patient. How many cells can you get? Well, you can basically achieve about 240-fold expansion. So it's quite relatively possible to treat almost 90 or make 90 constructs of 9 millimeters with a cell count of almost 3,000 cells per eye to basically treat many more patients than we can do with standard cadaver tissue. So once you've expanded the cells, of course, you've got to actually deliver them inside the eye. And the two ways of doing that is either through a cell injection approach, where you simply inject the cells into the anterior chamber, and then the patient would then have to posture face down for about 3 hours, or you put them onto some form of carrier, as you can see in the basically video below. So this is a video of two of our animal studies, preclinical studies done in Singapore. On the left-hand side, you'll see the cells that have been cultured in the lab, basically going to be transferred inside the eye on a basically carrier. The carrier here is a biological carrier, so it's just 50 micron tissue that are cut with a laser, and then they grew the cells on. On the right-hand side, you would basically see simple cell injection therapy itself. So once the model is created, you can see on the contact lens over there, this is an endothelial graft that's been with human cells but have been cultured in the lab, and we put it onto a contact lens, and then we load it into a device. In this example over here, you can see the endoglide, which we use for standardly for our DSEX and DMEC surgery. And on the right, you can see I've injected the cells inside the anterior chamber, and then this rabbit will then posture basically face down for basically 3 hours. On the left, the implantation of the surgery is very similar to what we see with ultra-thin DSEC or basically DMEC. Once it's basically pulled inside the eye, you simply just have to tamponade this with an air bubble. And this is very similar to routine ultra-thin DSEC basically surgery. If you look at the outcomes over here on the left-hand side, you see the control group basically in the middle, and the tissue, what we call tissue engineered graft, the TEK, in the middle, and then cell injection on the right-hand side. On the right-hand side over here, you'll see the charts basically compared to normal controls, and the tissue engineered grafts over here in the lower bar, in the lower line over here. The cell injection therapy is in this one, and this is a comparison of tissue engineered graft and cell injection therapy. The key caveat for this itself is that if you do tissue engineered graft, you will strip off the Descemet's membrane. If we do cell injection therapy, we don't take off the Descemet's membrane, we leave the Descemet's membrane basically behind. So clinically now, at the moment, there are 4 clinical trials basically undergoing around the world, and I'll show you the differences between the clinical trials. 3 of the trials involve basically primary endothelial cells. So what I mean by that, they're using primary culture where the endothelial cells are expanded and then they're basically given back to the patient. And this is the trial from Japan, Professor Kaneshida's group, MEHTA in Bascom Palmer, and our trial in basically Singapore. The differences between the trials is both the 2 above are cell injection therapy, and ours is on basically a carrier. The third study from which is published later on is a trial from Japan, from Tokyo, from Shimura's group, where they're using iPSC cells to basically resurface the back of the corneal endothelium itself. And I'll talk about the slight differences from this in a little bit more detail. This is a study from Professor Kaneshita's group in 2018 showing the outcomes from basically simple cell injection therapy. You can see excellent outcomes up to 1 and 3 years, and these were the first patients that underwent this therapy with simply injecting the cells inside the anterior chamber. And likewise, when you see a 5-year follow-up, they seem to maintain the visual acuity and also the endothelial cell count. A big caveat of this is if you look at some of the patients over here, these ones listed over here, these are patients who had a preclinical diagnosis of Fuchs, and if you look closely at the ones below over here at 6 months and at 24 months, you can see the guttae actually reappearing again on the surface over here, because remember, with cell injection, you don't basically remove the cutata, you just basically try to remove the dead endothelial cells before you basically inject the cells inside the anterior chamber. More recently, they published a paper in JAMA Ophthalmology, and again, you can see that the guttae actually started to appear between 6 to 8 months following the cell injection phase itself. And in the long-term group, basically, you can see that they actually remain stable up to about 3 years, but the guttae seem to basically be coming back. And then they classified this small series into 3 groups, patients with what they call typical guttae and basically no guttae group. And it seems that the endothelial cell morphology there is better in the non-guttae group compared to basically the guttae group. Currently now, there are basically 3 clinical trials already completed in Japan. There is a clinical product that's called Visona. Basically, you can see this below over here. That's available in Japan. Currently, the cost is actually quite high, but it's subsidized by the Japanese government. And there are 2 phase 2 clinical trials going in El Salvador and 1 in the United States as well. MEHTA is a slightly different technology itself, again cell injection, but the endothelial cells now are mixed with a magnetic nanoparticle, and then basically you inject the magnetic nanoparticle with the endothelial cells inside the eye, and then when the patient basically postures face down, there is a magnet to get the endothelial cells to stick basically onto the surface. The big difference between this technique and the technique I showed you previously is the endothelial cells are not removed. There's no basically surgical procedure. You simply just do the injection in the eye without actually doing any debridement or basically removal of any endothelial cells. Ellen basically presented some results at World Cornea Congress recently, and she showed that basically in their phase 1 study there was about a 38% of patients that had a 15-letter improvement, and now they're doing phase 2 dosing studies basically going forward and recruiting up to 30 patients as well. The third basically study is using a tissue and engineered graft, and this is what we've been doing basically in Singapore. This is some of the first patients that underwent this surgery. So we basically engineered 3 grafts because we had an IRB restriction on this itself, all from basically one 38-year-old donor. These are the kind of grafts that basically you get. So typical cell count, you can get well over like 2,800, even above basically 3,000. And then you have a QC control or validation of these cells itself. So it's a human donor corneal stroma that we use, but we basically put the engineered cells that were engineered and expanded in the lab, and then we basically transferred this basically to 3 patients itself. This is just an example of basically one of the patients who underwent surgery. So it's a patient with, obviously, generally for these we pick patients with poor prognostic eyes. They had this is the graft that came from the cell therapy facility. It's got a basically silicone cannula. They put it onto a contact lens to make it easier for me to do the transfer of the tissue, and you can see there's a slightly yellowish color of the stromal tissue over here because it's been basically in cell culture media for a week and a half. So once I remove the silicone sponge that basically protects the graft on the surface, we transfer the donor tissue with on the contact lens, and then this is loaded up basically into the endoglide device as you do basically for normal corneal transplantation surgery. And then I'll just basically put some viscoelastic protection on the surface. The contact lens is basically removed from underneath it, so it's like acting as a bit of a support. And this is a 50 micron graft that was cut in the eye bank, but obviously in cell culture it will basically expand, so it's slightly thicker when we do the loading. Just for the interest of time, I'll skip along the video a little bit faster as well. And what you can see is that I can't control the video. All right, but never mind. So basically we load up the graft to put it into the endoglide, and then this is basically put inside the eye, and the graft is basically inserted as you basically do for standard DSEC endothelium on the inside for protection. And then once it's basically inside the eye, then basically we tamponade this with air to basically stick this into position. So this is just like as we do with normal DSEC, and then all the sutures are basically then tied on the surface. Okay, so this is the outcomes that we basically can see. So this is pre-op on the left-hand side. This is day 1 post-op, 6 months post-op, and on OCT, all our grafts were basically attached onto the surface. And so far, we have data up to 6 months follow-up that we'll be publishing soon. The last technique I'll show you is basically iPSC cell generation. So this has been done in Japan. Again, what they will basically do, you'll see there is a removal of the basically endothelial cell layer itself, and then the cells are basically injected inside the eye. The iPSC cells are basically generated from a frozen stock and then differentiated into what they call endothelial-like cells itself. And in this one case that they basically published up to 12-month follow-up, it showed that there was no evidence of any teratoma formation inside the anterior chamber, and it certainly looked quite exciting. There is some functional recovery. You can see this is a patient with a previous penetrating capacity with poor visual acuity, but you can see, according to the follow-up, there was an improvement in visual acuity, and you can see from the central corneal thickness data, there is an improvement in central corneal thickness as well. I'll just show you one last thing that we've been doing more recently, which is what we call SNECI therapy. So this is a non-cultured approach, so taking donor corneas with less than cell counts of 2,000, and then instead of basically throwing those corneas away or not using or using them for dog, we're able to basically take off the endothelial cells using a very minimally invasive approach, stick them back into a syringe and inject them basically back inside the eye. And this has been something we've been working on the last 5 years. This is some of the animal studies, basically showed improvements in basic outcome, and we were able to get equivalent results with what we call simple non-cultured endothelial cell replacement, equivalent to what we're able to get with basically our culture techniques. And the cells are just delivered to the surgeon in a simple 1 ml syringe now, and we hope to be able to do first-in-man clinical trials in Singapore and a few other countries in the next basically year. So in conclusion, eye banking really and cell therapy really have to go hand in hand, and cell-based therapies offer exciting prospect to solve the global problem by de-skilling the surgery you can imagine to do corneal transplant with simple injection of cells inside the endothelium. It reduces the long-term use of basically steroids, and it increases the access to more people for the small incision surgery. There are some issues, obviously, with any GMP manufacturing. You have to think of new sterility issues, intensive manpower to do the culturing, and of course regulatory approval, which will apply to all these basic therapies. Now we're looking at more of transportation of these cells itself, and it may we see that the eye banks are evolving into cell therapy units as opposed to their traditional corneal harvesting techniques. Thank you for your attention.
Thank you very much,